Electrocast.
There's a change happening in the way we live, the way we work, the way we spend our money and make our decisions. We are evolving to be more conscious in our actions in a way that serves the world and makes it a better place. Welcome to the Ethical Evolution. The Ethical Evolution podcast is brought to you by Ethical Change Agency. I'm Bindi, I'm the founder, and my mission is to help ethical entrepreneurs and holistic healers to find their voice through spiritual coaching and podcasting. I'm honoured to bring you the stories of those who create change through healing, kindness, innovation, purpose, and spirit. Understanding that to create collective change, we need to be the change. It all begins with us. Hey, before we get into this episode, I just wanted to let you know that you can now grab my album of guided meditations. It's called Sourced by Spirit, and it's on all streaming platforms, including Spotify, Apple Music, Amazon, Tidal, YouTube Music, and many more. There's 11 guided meditations ranging from 4 minutes through to 10 minutes to help you reset your mind and your body at any time. Okay, now let's get on with the show. Jenn Johnson learned about intuition after listening to what her body was telling her. After years of nursing in the ER, she started to feel what was going on with her patients before tests would clearly show the diagnosis. Jenn has been an ER nurse in Canada for many years. With all of her experience at the bedside, she also realised that she could use her intuition, that gut feeling we all get sometimes, to get her patients the care they need much more quickly than if she waited for lab and diagnostic tests to come back. Her colleagues respect her as she uses her intuition to quickly communicate with others to get patients treated before they become even worse off. Join me as Jenn and I laugh and cry our way through her story in using intuition in her nursing career. Welcome, Jenn, to the Ethical Evolution.
Thank you so much, Bindi, for having me, especially at this very late hour. I super appreciate the time difference.
Look, this is not late, when I look at my watch, but I could just jam with you, I think, all day, which we've already got half done.
It's like, it's been great.
Yeah, so we're going to get into it so that other people can benefit from our conversation. But for those people who don't know who you are and what you do, can you go ahead and tell us?
Sure. So I'm Jenn Johnson, usually referred to as nurse.
Excuse me, nurse. Do you have a pulse?
Nurse. So I've been an ER nurse for 16 years, up and down Ontario. So the Canadian healthcare system well represented today. Have gone through just about everything, the bullying, the COVID, the short staffing, the hospitals big and small, going from an ER department that is just me running it to a trauma center. So have kind of been there, done there, seen. I'd like to say everything, but then when I say I've seen everything, something happens and I'm like, I didn't even think that was an option. So that's me. I've written a book. I'm trying to help support new nurses as they transition from nursing school into bedside, just because the rate of turnover right now is absolutely ridiculous. A new nurse will stick around 1 year, maybe 2, and then not just leave that nursing job, but like leave nursing forever. So trying to kind of staunch the flow a little bit and bring a little bit of the woo-woo into the medicalness.
And I think that's why you're with me today, because, I'm all about the woo-woo. But, when you mention Ontario, excuse my accent, I always think of Katie Lang.
I love Katie Lang so much. And I remember growing up listening to her and my mother listening to her. And when things came out about her being a lesbian, my parents were kind of not sure what to do with that. And here me and my siblings are going, but the song's great. Can we put the song on again? Let's go. Let's put the CD back on.
I'm trying to think of the song, and all I can hear is the lyrics. You know, there's a town in North Ontario. You know the song already that I'm talking about. Yep. I just love talking to people in Canada. And I think, you know, in all of my universal travels, I think Canada is going to be my next stop. So, you know,
we'll hit it up.
It's a bit of a long travel from here, just saying. But Jen, there's so many reasons why we're chatting today. And one of the things that really got me a bit jazzed to talk to you was the fact that you're not your normal nurse. And, you know.
Not normal, period.
Neither am I. So, you know, what I love about you is that, you know, you're real. You get down to business, get things done. But there's a little bit more to you than what you see on the surface. And I really love that you get to the core of, you know, what you feel as a nurse. It's not just about the stats, the measurements, the evidence and the test results. It's more than that. And I think that is super important when we're dealing with people, because people are more than just the flesh and bone, right?
Absolutely. Absolutely. Yeah. You know, coming kind of around to the idea that I'd been using my intuition while at work, you know, was kind of one of those things where once you figured it out, you're like, oh man, I've been doing this forever.
Yeah.
But but then it's very hard to come out and kind of talk about it, because you are like scared about how people are going to perceive you. And does that diminish your credibility as a nurse? And how do you go about saying something without it coming across like you're just way out into left field? The easiest way is just to kind of come at it like, I don't know. And really, how much of this did I know at the time? How much of it do I know now? How much am I going to know 10 years from now? Is going to be vastly different. So me in this moment, it's, you know, if somebody comes in and their vitals are okay, you know, their story is okay, their history is all right, there's nothing like super red flag, you know, that I've got to rush this person in. But there's something about all of a sudden I'll be sitting there and either triaging or caring for them in the back of the ER. And something in me either goes like, you need to stop and like really pay attention to this. Or it's a gut feel, like my gut feels like there's just a rock just hit it in an instant. Or there's just an idea that pops into my head to be like, oh, maybe we should look at this lab value that we don't normally order in the ER. So kind of following that through the years, and, you know, the more often I did it and leaned into it, the more often I was right. And so I'm like, okay, you know, and thankfully my second job was very, very busy. So you really didn't have time to think about it. So a lot of the literature actually says that critical care nurses, so ER and ICU, tend to trust their intuition a lot more, only because they're put into situations where they don't have a moment to talk themselves out of it. So they just go with it and they trust it and they're right and they move on. But they don't have that minute to even realize that they're doing it. Until, you know, you do a debrief of the situation, you talk about it, or years later you're talking, we've all got our little stories that we chit chat to each other, and, you know, and they come up with the words, well, I don't really know why I did what I did, but this is what I did.
Yeah.
This was the outcome. This was the patient outcome. And you're going, oh, well, that actually, like, you trusted your gut. And they're like, so trust your gut tends to be the more acceptable kind of terminology for it. As soon as I say intuition, yes, some people's eyes do glaze over just a little bit to be like, oh my God, you're that. And you're like, yes, 100% I'm that. Hence the Harry Potter Lego in my background.
I was looking at that.
I bought myself a Christmas present because I was like, you know what? You only live once. I've got the money. Let's just go. And so, you know, as soon as you say intuition, people kind of some people will tune it out. And it's those people that you hope aren't making patient decisions, like at the higher level. The joke is ongoing that, sometimes I work in places where they've got residents, so they are graduated doctors. They're looking to kind of specialize in either emergency medicine or critical care or internal medicine. And, you go to them and you kind of, based on what you know about the person, how many interactions you've had with them, you kind of gauge as to like, how much can I get away with saying right now? So you come up and you're like, hey, Mrs. X in like bed 3, I know that you haven't seen her yet, but like this has happened, like her blood pressure's, it's kind of soft, I just don't like the way she looks. And again, I don't like the way she looks or the way they look. I don't have a great feeling about this. My gut is telling me something's wrong. Can you come and see this patient?
Mm-hmm.
And the ongoing joke is that the new residents will be like, your gut? Okay, whatever. And we go back and we chart, no new orders received by physician. Physician notified at this exact minute, and no new orders received. And, you'll go back and you say, okay, so now blood pressure's a little softer and heart rate's kind of coming up a bit and their color's kind of changing. And now there's modeling on their legs where, the circulation to their limbs is starting to kind of not be so great. Maybe we can come and see them now. Oh, why? Your gut? And so if they put you off again, you're like, okay, no new orders received by physician. And if I'm really mad, I'll put the doc's name in the chart because I don't typically put the doc's name in the chart. But if I'm pissed, no new orders received by Dr. Smith. And so, we'll go on. And then sure enough, when that patient crashes, because they're going to crash, because we're not intervening, or they're having an episode that severely changes their acuity, then all of a sudden the residents in there going like, oh my God, whoa. And now we're in a tizzy because, this is going on. And it takes them a few instances of this happening, whether it's just by me or just by all nurses, where we say, hey, you got to come look at this patient, and they put you off. And then something happens where they start to go, okay, maybe
right.
There's more to this than I'm realizing. I'm really tired of intervening at the last minute. Maybe I should just take a peek. And that's all we're asking for, is just a peek. We don't want like a full head to toe, a bunch of interventions. I just want you to lay eyes on this person, tell me that it's fine, or maybe go, oh, maybe we can try this first while I'm, seeing other patients. We can start this, we can do that, that kind of thing. So, it's just a matter of experience. And, you get tired of having it handed to you day after day when the nurses told you hours and hours and hours ago that this was going to happen. So my docs who I've worked with for the last 5 years are absolutely phenomenal. They absolutely take me at my word. They drop what they're doing and they come see my patient, which I so appreciate. And, they've learned. Sometimes we just can't explain it, but I'm not coming to you with nothing. There is that moment of trying to learn what sick, not sick, really freaking sick is. And it takes that time to get there. But, again, if you want the science, even just having the doctor intervene or have them come look at the patient one more time still will improve the patient outcome. So if you're learning, you're not sure, you're like, I don't know, I don't want to bug them. This is their job. This is your job. You're not bugging them. You're just alerting them to the situation in the department so that you don't get caught in anything and that they don't get caught in anything. And that then we don't have to explain to family what happened, because Lord knows those conversations are absolutely awful. So just, trust your gut, go with it. If you're newer and you're just not sure, run it by a coworker. Like, just if your charge nurse is halfway decent, hey, I just don't know, can you come have a look? And if the charge nurse comes, has a look, goes like, oh man, nope, grabs the doc kind of thing. Like, you're still advocating for your patient. You're still improving patient outcomes, and you're still learning. And it's going to take time to learn, but I'm here for it. Absolutely.
Now, Jen, you may or may not have realised that a lot of the questions that I ask through these interviews are not pre-planned. It's all through intuition
it.
as well. So I had about 5 different directions when you were talking, and I have to pick one.
I mean, we could go on for forever, but you may catch my kids coming in and out of frame.
Yeah, invite the kids in. It's all good. Now, look, you've had a lot of experience as a nurse. Anyone listening to us is going to go, oh, yeah, that sounds a bit dodgy. But seriously,
Right.
You've had a lot of experience as a nurse. You've been through a lot. You've been through the whole pandemic of COVID. You know where it's at in terms of, patients, doctors, the whole collaboration, integration, all of that. And I know it must be hard sometimes when you see someone come in and you're like, oh, I already know what's going on here, and the doctor's going to do this, and I'm going to recommend this, but I'm not a doctor, so I can't do that. And you're kind of like, how can I try and expedite a solution for the patient?
Yeah.
And so, how is it that you can get over the ego of a doctor sometimes and go, you know what, you could save about 3 days in hospital here by just doing this? How do you get them on board to go, hey, I already know this is going to happen. How can we just do this now?
Yeah. It's one of those things where you absolutely have to be aware of which angle you're coming at. And again, which doc you're coming to. So if it's one of my regular ER docs who, we chit chat and give each other ribs all the time, it's like, okay, well, look this is happening. Can you just order this? Like, let's just save a lot of time. I know that you're busy with XYZ. Can you just order the CT now? Because I can't order the CT. The X-ray and CT techs get very mad if I order, the X-rays and CTs in our new system, unless it's under a medical directive. So can you just I know that this is going to be ordered anyways. We're just going to expedite this, and I'm very curious about this lab result. So can we just do this? And 9 times out of 10, it's like, oh yeah, not a problem. Because really, we know that we're going to, CT scan at least half the people we see. So for me to come up and say, hey, this is what's going on, can I just have a quick CT while we're waiting, so that by the time you see them, the CT report's already back, which, takes about 10, 15 minutes to maybe get a CT, and then the report takes about an hour to come back. So I'm just trying to combine time. We're just trying to save it. And really, if I'm pitching it as, I just want to save you time and have you do one less thing and get things started so that you have to see the patient one less time, which really equates to saving them an hour or 2 or 3 potentially down the road. When you come at it from that angle, that works pretty well. It doesn't really go over well if I'm like, I want this medication. Again, depends on your doc. But if I go up to my doc and we're looking at somebody's heart rate and they're in this rapid rhythm, and it's like, well, and the doc will say something like, but what about, DILT? What about diltiazem? What do you think? And again, it's always me punting back to the doc. What do you think? Because again, I am not a doctor, but I do have a lot of years of experience. So I value their knowledge. But I also have seen a lot of stuff and a lot of medications and a lot of situations. So, and they're free to say, no, we're just going to start with, the amniodrone. You're like, all right, okay, we'll see how that goes.
Sometimes they take the long game, doesn't it? They go, oh no, I wanted to check all the stops, and you're like, I don't think you need half them.
Yeah. You're just like, that's fine. We can tick all the stops. Because again, roughly half the time, that this patient's getting admitted the second they walk in the door. You're just going oh yeah, no, this is going to be a couple of days. But if you need to kind of pitch something a little bit earlier, then it's you probe the story a bit more. So you go to assess the patient, you kind of get that feeling I don't know about this story, oh, they were found on the floor of their home for, and EMS sometimes will say, 1 to 2 hours. Depending again on your ambulance crew, they're either good or not. So most of the medics I trust implicitly. There are a couple of crews that have burned me in the past. So guess what? I don't trust those crews as much. So I just go in, I say, oh, okay, Mrs. So-and-so, how long were you on the floor for? Oh, I'm not sure. Or they're confused, or they're really not looking so hot. And you're like, So for me, laying on the floor, unknown amount of period of time, I've got to rule out that they didn't have like a stroke and fall. I've got to rule out that they didn't have a heart attack and fell. I need to figure out if it's a trip and fall and have they broken a femur or a hip. And then the last one is always, way in the back. It's like, oh, if they're on the floor for an unknown amount of time, I want a CK, which is a creatine kinase, and it's a muscle marker for muscle breakdown. And so for some reason, these poor little people laying on the floor will have very quick muscle breakdown, very, very quickly. And so, if they are in a rhabdomyolysis, which is like just a normally high amount of CK in their system, what that can do is it can shut down your kidneys. And so, these little molecules of CK, what they do is they just block everything in the kidneys. So then if you're not getting enough fluid in and you're not peeing out enough, then we can get blocked and you can actually have kidneys die. And like once you lose a kidney function, she's not coming back. So, what's the harm in somebody just, it's just one test. It's just a little add-on. We're already sending that tube. It's just one more value. And so I've added it on because a lot of times we can order blood work when we first get started and that kind of thing. But, the few times that I've added it on, sure enough, have been through the roof. And the ER, there was one situation where, same scenario, little old lady on the floor for an unknown amount of time, came in, EMS is like, oh yeah, it was just a couple of hours. I'm like, I don't know about that. Look her over. She's not looking so great. So I'm like, okay, there's more going on. And with that on the floor for an unknown amount of time, I want to make sure that I double check the CK. So add it to the blood work. Blood work goes off. Sure enough, her CK's through the roof. And the son comes in and the son goes, oh, who ordered the CK? And I'm like, you know what CK is? Pardon me. He's like, I want to know who ordered the CK. And I'm like, I did. And I'm waiting to like just get my behind handed to me. And he's like, thank you so much. You just found the rhabdo, this, we can avoid this now. We can look into it. We can take care of it. And, the son goes walking by. I'm like, that was really weird. Sure enough, my doc comes up behind me to go like, oh, did you see that CK? And I'm like, yeah, I saw that CK. I'm like, who was that guy? He's like, that was our old director of ER. Who's a physician.
Oh, no way.
Oh, yeah. And that was his mother.
Wow.
I was like, okay. I'm like, all right. I'm like, I'm still not sure if I'm going to get yelled at, but like, I caught the issue. We fixed the issue, or one of the issues. Like, we'll just tack on some fluids, and like it's easy. That's the answer for a high CK is just fluids, just a ton of IV fluids.
And this is it.
And so we can run that.
You don't know who's coming in, do you? Or who their family are, or who their connections are. Look at how that pans out. Like you are performing at your most best, and when someone who's an ex-ER director comes in and you're kind of like, yep, we still got you, it's all good. They are expecting that and they are getting that, and so you are delivering that. That is incredible. But like seriously, it must be so hard at times to just be able to filter out the noise, to be able to find that intuition sometimes. How do you do that?
Sometimes, I don't know. Sometimes it's just what somebody says and it just kind of cues you up to be like, well, wait a second. And you just kind of stop. And then you're like, so triage is the perfect example of this, where you're just trying to find your basic story. So I know sick, not sick, very sick, right? And I'm just trying to categorize you. So we've got a 1 to 5 system. 1 is you need to be seen by a doctor yesterday. You are half dead. We need like immediate intervention. Whereas 5 is you could have gone to your family doctor a month ago with this issue, and you still should, kind of issue, right? So the wait times are all based on this 1 to 5 system. So when you're at triage, you're the one giving them the 1 to 5. So you're talking to them, and they're telling us that triage is supposed to take 5 minutes at tops.
Wow.
So they're coming in, you're getting a set of vitals, you're getting their, what they're coming in with, their medications, their history. And again, like just very quickly, just like, okay, like big, I've got diabetes, I've got hypertension, I've got history of colorectal cancer, and thankfully with the new charting system we're in, these are carrying over now where they weren't prior. So a lot of these are already pre-filled. If the patient's been seen in one of our hospitals before, you're like, okay, perfect, it's already there. So then I can skip down. And it's like, okay, well, what brings you in today? Well, I've just been having this pain in my abdomen, and it kind of comes and goes, and it's, I don't know what it is, and it's into my left shoulder. And I'm like, wait a second, left shoulder. Okay. Where's your abdominal pain again? Oh, it's, just in my upper, so they don't say upper right quadrant, but it's like upper right quadrant. You're like, okay, so that's liver, pancreas, gallbladder. Gallbladder would then hook up with the left shoulder pain. You're like, okay, but then that directs you. You pick up on something that then directs the questioning. And it really is, it's, is it assessment or is it an intuition? Because absolutely, like I've got the knowledge, skill, and judgment to be able to assess somebody very quickly and go and be able to pick up the right questions. But sometimes there are questions that pop up out of nowhere that, you're going, where did that come from? So perfect example is, it's 6 a.m. I'm done at 7. I'm way checked out. I've already triaged what seems like the entire world. This young gentleman comes in and he's saying that, he's got this history of pancreatic cancer. It's already been a month. He is having treatments. And he's having now an increase of pain where he normally hasn't had pain just yet. So I'm like, okay, so pain crisis, we go through that. He's about to, and I finished the triage. I'm like, okay, you're like a 2 to a 3, depending on your pain level. And I want you to be seen just because your history and, you're on chemo and you're immunosuppressed and all these things, which then changes the triage score. So I'm like, he was about to get up and go to registration to finish up the registration. And there's nobody else in the waiting room. And my buddies are all like behind me, gabbing in the nursing station. And out of nowhere, I go, how are you doing though? And he goes, what? I'm like, well, how are you coping with this? Like, you're very young. And I said, what's like, just how are things going on? And I go down this tangent of emotional coping where I normally absolutely do not have the time to be doing this at triage. Like, it's just not happening. And so we end up having this absolutely beautiful conversation about death. And I said, do you have any plans about what you'd like for your funeral or your celebration of life, or what you'd like to be done with things, that kind of thing. And he's just like, yeah, I've thought a lot about it. And he's got all these plans. I said, okay. I see the ring on his finger. I'm like, what does your wife think? He goes, she won't let me talk about it. She wants to nonstop. We're going to beat this. We're going to rally through. We're going to do all these things. He goes, but I'm of the mindset that I just want everything to be okay after I'm gone. So he's already come to terms with he's going to die, which is monumental for people. So we get talking. I said, okay. And he goes, oh, I've got this cruise, some sort of European cruise, like the river cruises. And he goes, oh, we're going on. I'm getting goosebumps.
So am I, actually.
The truth bumps. There we go. I'm like, okay, I get it. And so he goes, we're going to go in June. And I think this was like maybe January, February. I'm like, I would bump that up a couple of months. He goes, well, why? I said, well, he's like, do you think I'm going to die? I said, well, I don't know that. In my head, I'm going, but pancreatic cancer is like ridiculously aggressive. And usually people have 3 months in the back of my head. And I said, well, I want you to go on this trip and I want you to be well enough to enjoy it. I don't want you to be so sick that you can't enjoy those moments with your family. And he goes, I never thought of it that way. Okay. And so he gets up, he finishes, he registers. I turn around, everybody else is like looking at me bawling. And I'm like,
No.
what? They're like, what the fuck was that? And I'm like, what? They're like, that. Because again, I'm known to be quite sarcastic and a little bit of a mouthpiece and a cowboy. And they said, what was that? And I'm like, I don't know. I'm like, so now we call them caring intuitive moments because my one business, a few years ago was the caring intuitive. So I'm like, oh, it was just a caring intuitive moment. And they're like, all right. But we got talking about like death cafes and how you can go to these meetings either in person or virtually, and it's with people who are who either work with death or are surrounded by death or are dying themselves. Well, I mean, we're all dying, but like actively in the process of dying. So I said, find a death cafe and just go and listen. You don't have to go with your wife. You can do it yourself. But you'll have access to nurses, doctors, funeral directors, and get this very inside look at this end of life. And so it may give you some comfort in A, kind of preparing for what's going to happen. B, it gives you, I said, you're still very well. Like I wouldn't know any other way that you've got cancer other than you've told me. I said, but I would start making plans. I said, and during COVID, or actually during when my kids were born, I started a journal for them that was just like, I want them to know from, as my daughter wakes up, I want them to know from the moment they were conceived that they were absolutely loved. And all these memories of like, this was your first step, or this is just one day, or this was another day. And, to have that book of memories in my voice to them. Because again, time erodes memories, you kind of change things around. And hi, Peanut. Are you gonna, oh, there we go.
Oh.
Hi, sweetheart. Good morning. Hi. And, that's one of those things where when COVID hit and I'd kind of lost track of the journals, I'm like, where are they? They need to be, my husband needs to know where these are. My kids need to know where these are because heaven forbid I pass, they need these memories. So I suggested that to him. He's like, oh, that's actually like really, a really good idea. I said, you can make, you can book flower deliveries or other deliveries like years in advance, the whole P.S. I love you kind of scenario. And, there are things you can do now that will help you plan for later. And, if your wife's not ready to talk about it, these death cafes can help you work through a lot of these emotions, and give you a lot of perspective on what's going on. Because I'm like, I'm not just worried about you mentally, I'm obviously very worried about your wife and your kids kind of thing. But here are some steps that are very unconventional that are never offered at triage to kind of help you cope a bit better and get these things out now while you're well enough to get these things out now. So yeah, I turn around, everybody's bawling. I'm like, thanks guys that I start bawling because I'm a sucker. And it's just like, okay, like here we are. It's just one of those things where we're just on the move and on to the next. And, thankfully that was the last patient of the day that I had to triage. So I was like, oh, okay, I'm done. That was enough. No more.
My God, Jenn, your stories are like a journey. And like I said, I come up with 5 questions every time you talk. But one of the ones that is hanging on to me is, you've been through so much and you've guided people through so many really difficult situations, knowing that their end of time is coming. And I speak to people who are like their death doulas, they help people pass to the other side, those kind of things, and also people who connect with their loved ones on the other side and know that these things are going to happen.
Yeah.
How do you deal with the fact that these people have to find an end and helping them find their way through their last piece of time.
Yeah. I actually have a background in palliative care.
Of course you do.
So,
You've done all
of
the
course I
things.
do. Well, so to be fair, before I switched out of biology into nursing, I ended up completing 4 courses in palliative care before
Wow.
even starting nursing, which
I think
looking back
did you think that actually helps like nurses like get
yeah.
through like the everyday,
Huge.
particularly big things like COVID, because like having that background of how people pass and dealing with the end of life and all that kind of stuff, surely that has to give you some foundation through all of the shit that comes on the other end of life, right?
Absolutely. Well, because like it changed my whole perspective, right? Because nursing school is like save them, save them, save them.
Yeah.
Palliative care is make them comfortable,
Yeah.
help them. Like you're still helping, but you're helping in a different way. And so having that perspective before really delving deep into nursing school was absolutely something that I'm so, so thankful for. Because going through nursing school, you know, again, the focus is on you're going to save them all.
Yeah.
You're definitely not going to save them all. That's not my job.
Yeah.
My job is to try and save you. And then when we reach the point of not being able to get there, then it turns into how can I make you comfortable? How can I involve the family so that their suffering is like minutely decreased so that they don't have like a ton of trauma coming away from the situation. They're going to have trauma regardless. I'm just trying to minimize it as best possible. You know, how do we get to the place of being able to very comfortably talk about death with families who are very not ready to talk about it? So even actually just yesterday, I was seeing a client, you know, random home care visit. So I went to go and she's talking about, you know, she's worried about her dad and he's had this like weight loss and all this kind of stuff. And in my head, I'm going like, okay, that's a really significant weight loss in a very short time. So with that comes the automatic thought is cancer, but he just had like a very major surgery 6 weeks ago. He'd gone through it all. And so they're just trying to cope at home and they're trying to find resources and all this kind of stuff. So I said, okay, well, how is home care coming? Is home care coming into the home? She goes, oh, we actually were, we didn't qualify because he's not sick enough. I'm like, okay. I'm like, well, that's kind of good, right? So that's one way to take that is that he's well enough that he doesn't need, you know, the level of care that they provide. I said, however, there are a few tricks around getting there. I said, a lot of the paramedic programs or paramedic services in Ontario have not just palliative care teams that mobilize and take care and, you know, check in at people at home, but they've also just got home health paramedics that will come to your home. They'll do a set of vitals. They'll see where you're at. You know, if you're worried about should I go to hospital or not, they've actually are absolutely fantastic at being able to help you make that decision. So I said, you know, here's that referral. And she goes, I didn't even know that existed. I'm like, absolutely. Here you go. I said, the other thing is palliative care. I said, and I understand that with palliative comes that connotation of they're going to die now.
Yeah.
I said, if you can come to terms with just the fact that palliative is just a word, if you can take that out of the equation, the amount of services and supports that you can access due to that word is excessive, like phenomenally excessive. Like I am so thankful that we've got so many programs in place and supports for to try and have people continue to live in their homes as absolutely long as possible and potentially die in their homes if that's what they wish. You know, to have them be comfortable, be comfy in your own bed, not in an ER stretcher where you're going to wait for 100 hours in my ER to then hit the floor. You know, it's not ideal for anybody. And then, you know, get a little delirious because of the beeps and the rings and all the stuff that's going on and not get any sleep kind of thing. So I said, if you can take that palliative care word and just glaze over it, I said, wouldn't it be easier if we got things set up in advance so that you could continue to stay at home and have supports come in and you feel better, because obviously the daughter was not coping. She very much was overtly worried, and to her credit, had like all of his CTs and ultrasounds and MRIs and lab work and consult notes. She had them all printed out and in front of her. And so she's like, here. I'm like, wow, I am impressed. Okay. I said, but, you know, saying that he's palliative or applying to get into the palliative care program does not mean that we are not treating right now. It has no bearing on treating right now. I said, you know, and so we had the code status discussion, and he still wants to be a full code. Mind you, when he answered, if I said, you know, if your heart were to stop, do you want us to do chest compressions? Do you want us to put the tube down your throat? And his answer was like, well, you know, do whatever you think is necessary. I'm like, not quite how that works. I'm like, okay, but whatever. We've opened up this conversation. You've decided that at this moment you're a full code. Perfect. We've at least talked about it. That's all I want to do. Just open the door, just talk about it. So I said, you know, I've had palliative care patients in the past who I'd seen for a year and were actually discharged from palliative care because they suddenly were doing quite well. I said, so if you can get over that word, there are resources upon resources that you can have access to. She goes, I had no idea. I said, okay. So, and they were going to the specialist clinic today. So I'm like, okay. And then when you go into the specialist clinic, I know that you're going to be a little extra. So we're just going to have to dial this back just a little bit. I said, what are your 1 to 2 absolute main concerns that have to be addressed? And again, it's kind of triage, right? Like triage your needs. What needs to be addressed? Well, the weight loss needs to be addressed. Absolutely. 100% the weight loss needs to be addressed. And then B, he's so nauseous. We think it's the medications, that when he takes the medications, he gets nauseous. And then he also gets this metallic taste in his mouth. I'm like, okay. Like, you could go to your pharmacist, talk to your pharmacist about the medications, see if any one of these medications have that side effect, and then maybe just take it at night. If it's just once a day, maybe you just take it at night. You can be nauseous while you sleep. Fine. Great. But then that's preventing him from eating, which then the weight loss, and we spiral down that way. So I said, you know, I walked out of there going like, okay, you know, do I think this is going to go really, really well? Debatable. But at least I've opened some doors for them. They're going to hopefully get access to palliative care, because do I really think that maybe in the next 6 months, if we continue down this road, will he need it? Yeah, I do. Am I hopeful that maybe it's just a blip in the road and 6 weeks post surgery and that's the issue? Sure. But it's already been 6 weeks and we're still not where we need to be. So let's get all this organized. You know, if we can get OTP, so occupational therapy, physiotherapy into the house, because he is still getting up and moving around. Let's keep that going. But also in the back of my mind, am I also using the palliative performance scale to see how bad things are? You better believe I'm, you know, and he's falling asleep in front of me, like midway through sentence. He's very easy to rouse, but in an instant, he's falling back asleep again. So I'm like, okay, that's, you know, and again, let's look at meds. Let's do this. Maybe change that. So, you know, just trying to coach her to see like, listen, for your appointment, this is going to be the thing to get you the best thing out of your appointment. I said, and she kind of said, well, I just want to scream at them. I'm like, I understand you're frustrated, but no, that is going to get you put at the back of the list. That behavior is not going to work to your benefit. So I need you to put on your happy face on this one. And again, you just have to put it on for, you know, 15, 20, 30 minutes, maybe. I said, that's all you need to do. I said, because the second you kind of get labeled as a troublemaker or somebody who's very aggressive, you better watch out, because that's getting put on dad's chart. And once you come in also with him, they're going to know, they're going to be notified. So in order for this to go as well as it can, I need you just to like dial it back. I need her to get some sleep is what I need.
Right.
And a little therapy.
Like there's so many things that are hidden in plain sight too, aren't there? Like, you know, like as a nurse, you would see this too. And I've spoken to many people who were previously or are currently paramedics, where they get a little bit pissed off because, you know, people are their own worst enemies, right? So they are causing the problems that they present to you. And you're like, oh, well, here we are again. You've not followed the instructions we gave you, and here we are again. And like, I don't know, it's kind of a little bit perplexing, isn't it? Where, you're presented with someone, and I often joke on this podcast, Jen, you're really going to love this one, but most people are not aware of the meat suits they're in, right? So, they just think it's this thing they've been delivered and they got to deal with it. But, you got to kind of look after it and you got to know how it works. And most people don't, is my biggest problem on this show. So, if we can take anything out of this conversation is be aware of what you're doing to yourself and how you're ending up, because a lot of the problems that you're getting are actually self-developed. They're not anyone else. They're not just genetic. They're not all these things. Sometimes it's you. That's the problem. Yeah. Sometimes we need to look in the mirror and realize it's us who's doing this to us.
It's the really ineffective coping mechanisms that work in the moment, but really long-term issues. So I'm thinking marijuana right now. So with cannabis legalizing, thank God through COVID, because I think that's the only reason half of us survived, so people are coming out now that they've got such they're doing it so frequently and so often and needing increased dosages of gummies or oils or whatever or smoking or whatever, that they end up knocking themselves into a hyperemesis, a cannabinoid hyperemesis syndrome.
Oh, wow.
Oh, yeah. So if you want to puke your brains out for up to 6 months after quitting weed.
Holy crap.
This is what could happen, right? And so these poor people, they come in, they're quite thin, and they're just retching and retching and retching. And there's nothing you can do. Gravol doesn't work. Ondansetron or Zofran does not work. All these things. So we end up going... So they figured out that peppercorns, so pepper spray, the peppercorns that are used in pepper spray, they've put it in a cream, and the cream put on skin will help this come down. We don't know why, but it does. There's also an antipsychotic medication that we can give you either IV or IM, so either a shot or through the IV, and that will also help quell the vomiting. The problem is, even if you decide, you've had this one episode, guys, can you turn it down, please? Number 2's up. Why, guy? All the way down. I'm literally talking to somebody who's in Australia right now. Can we not?
Turn it down, kids. Come on.
Come on. And so, even if you quit, you have one episode, you quit, it can take up to 3 or 6 months for those symptoms to go away.
That's insane. That's a long... wow.
It's excessive. Granted, it also takes, quite a bit of time where you're doing it every day, potentially multiple times a day, for a long period of time.
So that's like high consumption, right?
Yes. Yeah. It's like an alcoholic, right? Where your body gets used to functioning on alcohol. So once you take the alcohol away, you can seize. Because your body just goes like, pardon me, like this is not our norm. So it's, drinking all the time heavily to the point of not being able to do anything, smoking marijuana, other illicit drugs, anything that you're using to cope and just get out of a situation mentally, sometimes does not, most often than not, does not work to your benefit. And then not only do you have to deal with that and the therapy that absolutely seems to need to come down the tubes, it will also be that now you have to deal with any symptoms that are lingering because of this, and any secondary diagnoses like alcohol cirrhosis or alcoholic encephalitis, where you actually kind of pickle your brain and you get like Alzheimer's super, super early, or symptoms like Alzheimer's very, very early because your neurons are just shot.
Are you seeing a lot also at the moment? I'm just curious on the back of that, from vaping. Like here in Australia, they're banning vaping. They've also banned smoking. Like smoking, we've had the best campaign in the world apparently, but people have gone to vaping and now they're going back to smoking. So are you seeing people pretty much pickling their lungs or worse from vaping?
I have seen, I think maybe one where the vape has exploded in the face.
Oh,
That was
get
pretty
out.
bad.
Oof.
That was bad enough that I'm pretty sure that patient had to be intubated to protect the airway.
Oh,
Um, and then, I don't know how much we've actually been attributing to vaping specifically, because again, we're still a kind of a smoking society. We're trying to come down on it. And yes, most of the young people are leaning towards vaping because of the candies and the colors and all
yeah.
these things that we shouldn't be allowed to,
Exactly.
advertise to children. But, and my sister vapes, and I keep having this conversation with her, be like, I hear about all these, like the popcorn lung
Yes.
effect where, your lung gets like scar tissue, and it's just like, and it's happening
done.
at far faster rates than
Yeah.
just simply smoking alone. And her answer is like, well, this way I get to like cut down. I'm like, yeah, but it's not like with cigarettes where we can go, are you doing like how many cigarettes in a day? It's a very quantifiable, is it a couple of cigarettes a day? Is it half a pack? Is it a full pack?
It's hard to measure, isn't it?
Versus vaping, where it's like, well, how often do you vape? Well, I don't know. It's like, and fair, because so I took my sister and I went on a cruise, and I had no idea how much she vaped. Like it was a constant, just kind of, oh, we've got to go down to the casino because in the casino I can vape, and oh, we've got to go to that one side of the boat because there I can vape. And I'm just like, man, I had no idea. Because again, when you see your family for just small periods of time, people can hide all sorts of stuff. I'm just like, well, that's good to know. So again, I tried to give her the what's for. She's kind of on the opposite side of things where, everything's a conspiracy first.
Sorry,
like,
sis.
I love you too much to not tell you this.
Exactly.
You're an idiot. You're an idiot. And you're probably one of the few people that I can full on tell outright that you're an idiot for doing this. I said, I love you. I care for you. I do not want to see you with, so those who have smoked for long periods of time get COPD, so chronic obstructive pulmonary disease. And you will watch these people struggle for every breath for years. It is horrific. And these poor people, their whole world revolves around where's my oxygen?
Yeah.
Where's my oxygen at? And, they turn into these little teeny tiny slight people because they expend so much energy with every single breath. And it's probably one of the sadder things to watch. Because again, most of these people are 70, 80, 90, and they're already way past the point. There's nothing we can do at this point. So
It's
when
almost
people
worse
are like, oh,
than
you need
alcohol.
to quit smoking and this, that, and the other. And here's the palliative care side of me going like, we're not going to change a behavior at 85 years old. Like how likely is that?
Yeah.
How likely is it that they're just lying to you about quitting smoking so that you stop with the quit smoke spiel? I get it. I understand. But again, this is when we start to look at quality of life versus quantity. So if you want to continue smoking, which then you can't have home oxygen because of the lovely combustibility of oxygen with flames or cigarettes,
Boom.
that's going to be a problem. So they won't give you home oxygen unless you quit, is what it is. But, just as long as you're aware of what's going on, if you're the one to make that decision, same with my husband's grandmother, really brittle diabetic, ended up getting to the point of losing a limb and getting on dialysis. And they tell stories about how they would take her out for ice cream right before going to dialysis because she wasn't supposed to have ice cream.
Oh, no.
I'm like, okay. I'm like, I mean, it was a way to balance a little bit quality and quantity. But it just was, it's hard to hear those stories and to know, like, this was way before my time with him. So I never got to meet her, but, sounded like she was a lovely lady. And that's exactly what, made her happy, was getting ice cream with her family. It was when they would go into town, to make the 2-hour drive into the town where she got dialysis. So that was like 3 times a week, I think, for, I don't know, months, maybe a year. So I get it. I can play devil's advocate if you want me to play devil's advocate.
Jen, it must be so rough though dealing with those kind of conditions when you know that they are preventable. And, I've had people on this show who have ended up with cancer on the back end of transplants from, those kind of things, and have had literally months to live. And after having those kind of conversations and then seeing people who are literally killing themselves day after day, breath after breath, it just really, I don't know, it does something to my core.
It's hard.
Yeah.
It's very easy to be judgmental. It's very easy to like come to those snap judgments. And again, I've been there. The people who are coming in with IV drug abuse, you're looking at them and you're like, again, like, you've got to be kidding me. And you're so sick and we're having to do all these things and you're playing me like a fiddle until I get to the point of being so hard that I can't be played anymore. And then I'm mad because I'm hard and I'm it feels like I'm losing my caring, but in reality, it's just me shielding it because, if you break through that shield, chances are not good for you because that's usually the only time people break through. But it's like, okay, let me take a step back. And this is therapy talking. Let me take a step back. Why are they doing it? Because again, it's not like people don't know that drugs aren't bad.
No, they're doing them for a reason, aren't they?
What's led them to this point? What trauma have they endured to let them get to this point of, they're still living. They haven't tried to end things. But they're just trying to get through the day also. Yeah. Right? And it's just this spiral where, okay, you've had this trauma, now you've picked up drugs, now your family refuses to talk to you, now you're full on hooked, now you're, homeless and you're having to do things for money that you really would prefer not to do. And now you need those drugs to do those things to be able to live. So it's just like, I try my best to take it back. Sometimes it's very, very hard, especially with the people who are very obviously trying to manipulate the system and try to play the system. Yeah. But every now and again, you come across somebody who, they're aware enough of it where they go, I know that this is no good for me. I know that I shouldn't be with that guy. I know that I need to get out of this situation, but like, I'm already banned from a couple of shelters because of past behavior. So I have to wait. And then I don't really have a home. And like, do I put up with the guy because that at least gives me a roof over my head? And it comes down to very basic needs. And so it's hard. If you actually were to listen to people and get the full story, it's very hard to kind of be as angry as you once were. Still angry occasionally, when it's the same person multiple times again.
I know.
And on top of it, they're awful to you.
Yeah.
Then you go, not really feeling this. So, if you could just go, that would be great.
Now, Jen, I'm going to just go a little left field before we come into our landing, if you don't mind. I'm one of those people who loves my reality TV. Well, it's not really reality TV, but I love Chicago Med, can I just say? And you probably do too because, look at you.
I haven't caught on to that one.
Oh, come on.
Grey's Anatomy has been carrying me through. So fun fact, when I swapped into nursing, so my first year of nursing school was when Grey's Anatomy first come on. And the fact that it's still running, so it's been on my entire career.
Oh, come on.
I'm like, I take this, I'm going to be devastated when it ends.
Jen, please just go and watch Chicago Med for me because I think there's about 8 seasons, but when you learn and understand what, some of their rules are around, like really, like, so it's an ER, right? Yeah. And they have these rules around like significant trauma, like when there's the really bad ones, that's, what do they call it? Baghdad. So when it's really bad, you go into Baghdad. And so I was completely obsessed with Chicago Med. and how it worked. And I think there was a while back, a couple of years ago, I was really sick and I actually binged Chicago Med. Not a good thing to do when you're sick, right? And so I did that, and I think I just about know how to intubate someone right now after watching so many episodes of it. But I think you got to check it out. But how much do you see in the media and these TV shows like 911, like Chicago Med, all these kind of things, Grey's Anatomy, how much of it is bullshit?
Absolutely. When was the last, so the ongoing joke in the nursing community is, when was the last time you saw 3 doctors walk a patient?
All right. There's never 3. There's always 1, right? If that.
Never one. Never one. It's the nurses. Please mobilize patients. So now I've got to play physiotherapy on top of nursing.
Oh, boy.
And hopefully not kill my back in the meantime. But yeah, is it accurate? No. However, to Grey's Anatomy's credit, their COVID seasons, I was obsessed with their COVID seasons because obviously I was not in a great place, but they were so on point with the emotions surrounding COVID and surrounding working during COVID and all the fear and all of this. It was so on point that I would watch it, bawl my face off, then have a meeting with my therapist, and my therapist go like, maybe if it's upsetting you that much, maybe you shouldn't watch it. I'm like, no, but like, I can't believe there's an accurate representation as it's happening to the population of both Canada and the US and anybody else who's got access to Grey's Anatomy. I'm so proud of them for doing it so well.
It's like well. You can't be what you can't see, right? Like having that relatability.
Yeah. I was kind of convinced they were going to kill off the main character because she got COVID, she got intubated, she was one of these long COVIDs. And I could have sworn, I'm like, I don't want it to happen. But at the same time, if they killed off the main character dying of COVID in the US, you wonder how much of an impact that actually would have had with people who were on the fence as to like, is it believable? Is it not? Yada, yada, yada kind of thing.
Yeah.
So I was like, I wonder. They didn't end up killing her off. But again, she had like long COVID, and then she had all these like dreams with past characters that had moved on or died previously. And I'm like, I can't do it. It's like one of those things where I'm like, this is just, I don't think I've watched them since. Again, also because they're hella triggering, but so on point. And that's why they're triggering. It's just because they were just absolutely rocking it with nailing the whole scenario. It was just fantastic.
I think they're super important, like for the community in general. But I guess from someone who's been in the trenches, it's really interesting to see your point of view and what you think, like, I don't know, they usually have a technical supervisor of some kind, but,
they do, but those people are all.
So it's like, it depends.
If you get on any one of our medical pages, which kudos if you pass the questions to get into any one of these like Facebook groups kind of thing, it's nonstop pictures about people on TV or in shows or in movies and like how horrible the representation of like, so the thing that we use to spike the IV as like an IV in the hand. And I'm like, what the heck? Or like suction tubing, just straight for an intubation kind of thing. And you're just going like what was the ongoing joke? That the tube, so Derek, who's married to the main character of Grey's Anatomy, he ends up, sorry, spoiler alert, dying. This was many years ago. He ends up dying from a head injury, and the online community went nuts because if you look at the ET tube, it's taped at 2 or 3 centimeters when normally it's supposed to be like taped at 8. You could have cut that tube to like tape it at 8. Come on. Who are these people advising you?
I know, like, I'm not a nurse, but I've had, a lot of, safety training, first aid, all that kind of stuff. But, like, I've never intubated someone, but I'm pretty sure I've seen enough by now. And I'm just like, I still, like, the way you do it on TV, I don't get it. Like, like, you just look at it and you see that metal tube, then you see the plexi tube, and I was like, wait, stop. Can I just, I need to analyze this for a second. I've seen so many, I feel like I've done one myself.
The only thing you're not seeing is that when you actually intubate, so we've got glide scopes, so it's actually got a camera on the end so that it can help the doc kind of really make sure that they get proper placement. There's looks like a woman's parts.
Yes.
And that's where the tube has to go through.
Right.
And so that's what you're not seeing on TV kind of thing. And you can, if you miss through the, oh my God, I'm blanking on the name. But if you miss getting it through the hole, you can go into their esophagus, and then you've intubated into their stomach.
In their stomach rather than their lungs, Yeah,
wow. And then you're just like, I don't hear lungs. Like you're checking out, I don't hear lung sounds. And you're over the stomach. You're like, yeah, no, sorry, pull it out. We got to try again.
Oh. Anyway, I've just seen so many. It literally fascinates me. I'm sorry to obsess on it, but I've seen so many. It fascinates me, and I must learn it one day. But I'm not a nurse. You are, so that's what we're here for.
If you take ACLS, so Advanced Cardiac Life Support, they teach you how to intubate, and you can practice on the dummies.
Oh, I've done CPR, the whole thing. That's
so
the next step.
Level up.
Yeah, right.
The next level up. Oh. Granted, they also test you on cardiac rhythms and meds for cardiac rhythms and when to pace somebody electrically and what the voltage is and this, that, and the other. So I mean, it's a 2-day for the first time. It's a 2-day, very in-depth.
Jenn, I feel I have to go down this path now. You've inspired me. I could save a life.
Absolutely. You probably already have, to be fair.
Well, through this podcast, after over 200 episodes, I hope I've saved someone's life. But we're here for you today, not me and my fascination with intubation. I could talk about this stuff all day, as you could understand, but
absolutely,
one of the things,
right there with you.
One of the things I want people to know, if they're listening to this with us, is how they can find out more about you and get in touch.
Yeah, so I'm on TikTok and Instagram at ernurse.jenn, Jenn. You can find me on LinkedIn, Jennifer Johnson, BSCN RN. For the nurses, don't come for me. There's just a million Jennifer Johnson, so I had to do that. My website is RX for Growth, so prescriptionforgrowth.com. My book, Nursing Intuition, where are you, baby?
Get it out, girl, get it out. There we go.
My book, Nursing Intuition, is due for release October 29th of this year, currently for pre-sale on Amazon for the ebook. And I've got a couple of journals about grief, wellness, and 100 shifts for any new nurses. It's a great gift just to kind of help them keep track and grow as they move through nursing. So you can find me on Amazon, Jennifer A. Johnson RN, and that will lead you to my author page, which has got all the other things.
I love that, Jenn. And I did want to go way down the path of intuition, but I didn't with you because I was so fascinated in intubation. I'm sorry about that. But I think we might have to get you back so that we can go down the woo-woo side and not the physical side. So 100%. Sorry about that.
So worst comes to worst, science has proven intuition.
Oh,
and science has proven intuition in nursing. If that's the only takeaway, you can call me as crazy as you want. That's cool. But there's science behind me and recent science and a lot of it. So, if you want to take this to your people, fantastic. The book started out as a trauma journal. So take that with a grain of salt.
Now, there was one question that's been burning in the back of my mind among a million since I've been talking to you. But I'm going to hit it before we hit our last question, and that is, I know in the States and Canada, for that fact, it might be a little different there, but I know the medical systems are quite challenging in comparison to where I am. Mm-hmm. Where I live, we live under a system of what we call Medicare, and it's all covered by the government or our taxes. So I know in the States in particular, there's a lot of people who have gone bankrupt because they can't deal with their medical bills and therefore can't get any further health care. Are you seeing that where you are right now?
No. So Canada has got OHIP. So that's our Medicaid. So you go into a hospital, you get testing, you get imaging, you get referred to a specialist, everything is covered. You will never, well, that's not true. You will see a bill for things like crutches or leg splints or assistive devices, but you will never see a bill for a stay. So, in talking to a lot of Americans and discussing again, obviously their healthcare system, I don't understand. I don't get it. I don't know how their health insurance works. I'll flat out say it. But for us, I think a lot of issues are solved with preventative care and being able to access a physician without the worry of a charge. So, you will see your physician for that niggling cough, whatever. So you go see your family doc. In the States, many people have to wait until it's a true emergency before they can go to the emergency room because apparently, allegedly, they won't be seen unless it's an emergency. Unless they can provide proof of insurance. So, that's the one thing that, talking to Americans, they're just like, oh, the healthcare system, like, you'll wait. It's not perfect. You'll wait, but it's free. Like, I'll take that. I'll take the wait, and really, if you needed something ASAP and it was an emergency, you would get it.
Yeah, it's incredible. I've spoken to so many people in the States that have had issues around getting healthcare. And like when I was there a couple of years ago in LA, I had to go help a friend pick up a prescription just from the chemist, pharmacy. And I went and I picked it up and I saw the price tag on the prescription and it was something like $230. That's like nearly $500 here in Australia. And I just went, wow, we have a prescription benefit scheme here in Australia where you would pay no more than $20 for that.
Wow. Canada, many people have drug coverage through benefits through work. But if you don't, you're paying out of pocket. And the same thing, like, a puffer, a rescue inhaler for asthma will cost you, $110.
It's $8 here. $8 for Ventolin. $8 for Ventolin. No joke.
So if you can afford the flight to Australia,
come down here.
Bring it on back. And I think actually Michael, oh God, what was his last name? The guy who did Bowling for Columbine, who also then did Sicko at 9/11, Fahrenheit 9/11.
Yes, he passed away, didn't he?
Michael.
Didn't he pass away from the Big Mac thing?
I'll have to Google. I don't know. I hadn't heard anything, but he did a documentary on healthcare. And so he went to Canada, he went to the States, he went to Cuba, he went to Europe somewhere, and just all the different places had such different things. And here he went to Cuba and, his friend, so they had taken a couple of people who had worked during 9/11 and had chronic lung conditions afterwards. They took them to Cuba. They got worked up, they got medications, they got all these things, and they could take all these things back. And, and they're going like, what do you mean? It's like $2 Cuban for a puffer. So like they came home and their suitcases, like very large suitcases, were just packed with puffers because of course you're going to go through puffers left, right, and center.
Isn't this crazy?
It's
like worldwide, can't we have a universal kind of standard where no matter where you are, it's the same kind of thing? Like, why is it, in America, a puffer is $140 and here in Australia it's $9? Like, why does this happen?
I don't know.
And I get, there's like different suppliers, different everything, and the dollar and all of that kind of stuff comes into play. But still, like, some of this, like, do the drug companies, are they just like milking us? Like, that's a whole other podcast.
That is a whole other podcast. Because again, like, I don't know for sure. I do know that, what was it? There was some person who had applied for a patent on, was it some sort of insulin or something? And the insulin was actually quite cheap to make. and then he jacked it up to like 100 times the profit.
Yeah.
I think this was in the US. I think this was a few years ago, but people were outraged. And I'm like, absolutely. And really in the US, something that you're born with, so type 1 diabetes, where it's just there wasn't any sort of factors other than just chance in play. And same with Canada. I'm quite upset when a diabetic can't afford their insulin. Like, I'm like, do you understand that then equates to like not only time in hospital, efforts of staff, costs of keeping that person in hospital, cost of all the medications to reverse everything and correct it, and like for what? Like
One person,
$100?
1 year, those costs, they could cover it, couldn't they, really?
Absolutely. Absolutely. And like some of the I do know that some of the drug companies in Canada, you can apply to their programs and have help with medications being covered. And it's not just insulins, it's a lot of medications, but that's specific by drug companies. So if you're on 5 different medications from 5 different companies, now you're having to fill out 5 different forms every year, potentially.
That's
like
insane.
it's a full-time job to be sick. Honestly.
That's just crazy. And like I just heard this morning, one of the alternatives to Ozempic, I know it's a whole other thing, but
again, it's another
but I did hear that Manjaro is now more available, but within the next 3 years, that'll be off trademark, and then people can then like do a generic version, which will be a tenth of the cost, particularly here in Australia. So that's all it takes is to wait a couple of years till it comes off, trademark, where they're not the sole exclusive suppliers of it, and then you can get it cheaper. So this is how these things work. And it was the same with, like, look how fast they developed COVID drugs and all those kind of things. Within a matter of months, they put something up, and then the next thing you know, oh, look, we've now gone past the trademark and it can be so much cheaper. Oh, you don't need it now? Oh, bugger. It's kind of like this cycle of how things work. And it's all about money making, isn't it?
Yeah, a lot of it. You can't help but be a little bit jaded. I mean, I'm absolutely less so because everything is so available in Canada and obviously for a lot less of a cost versus the United States. But, people are trying to bring in private care, like let's bring in some private care clinics. Let's bring in some And I'm like, I get it. But at the same time, you're only going to then widen the disparity between available healthcare.
Yeah.
And Canadians are absolutely petrified of going anywhere even near private only because of what's going on in the States. So that is our only saving grace to continue to really push for universal healthcare over here and to keep it, is because, do you want to have to sell your house because you couldn't afford to like have a baby?
Yeah. No, that stuff's going on in the States and it's going beyond repair. Sorry I went down that rabbit hole, but
I'm all about the rabbit holes. The rabbit holes are the fun part.
My last big question for you, Jen, is what's the change you'd like to see in the world and how would you bring it to life?
People being able to see outside of themselves. People just having even a 1% increase in just the awareness going on around them. Because it is so easy to put on blinders and just only, end up caring about yourself because that's all you're experiencing. But open your eyes and see what's going on around you. You're in the ER, you're upset, you have to wait. Open up your ears and your eyes, and it will take you 5 to 10 minutes to figure out, maybe I'm not the sickest one here. We can't say anything, but the ER is very loud. The ER is not the greatest place for keeping private things private. We try as best we can, but sometimes due to constraints in time and area, I'm sorry, we have to give you this cancer news in a ward room. God. Or in the hallway. Oh, we had to do that the other day. That was not fun. So, just please, anytime you want to be upset with how things are going, just take one half step back and just take a look around you and see what's going on in your immediate area. Because I guarantee you, somebody is probably as bad off, if not worse off than you, if you actually looked around.
And I think on the flip side of that too, Jen, is like put yourself in the shoes of the person who's got to deliver that news.
Yeah. Have some empathy.
Yeah.
Please.
And also for, everybody else around you,
Yeah.
I think sometimes we're too busy in our own space and up our own butt sometimes that we don't have a chance to think about, well, how's it for the other person on this side of this conversation? And I think in everything we do, whether it's ER or anywhere, if we can take a moment to just see the other person's perspective, I think it will really help us understand that it's not always about us, even though it might be. It's a bigger picture.
We're egocentric, and it's just the way of the world. So I understand that it comes very naturally. But just I dare you to take a half a step back. I'm not asking for much, just half a step back.
Jen, you are a earth angel, can I just tell you? You are just like a delight. Thank you so much for everything you do and for everyone you save every single day. We thank you for your service and thank you for being a part of the ethical evolution.
Way to make me cry last minute.
Oh, sorry.
Okay. It happens. We don't hear thank you very often, so it's always a little bit of a shock to the system.
No, we thank you, and I understand everything you've been through and everything you do and everyone you've helped. So thank you so much on behalf of them and everyone who's listening today. Thank you so much.
Thank you so much for your time.
Thanks for listening to the Ethical Evolution Podcast. If you're ready to be the change and would love to work with me on finding your voice through spiritual coaching or creating your own podcast with impact, visit ethicalchangeagency.com. If you're enjoying the show, please subscribe to the YouTube channel. It's growing every day with great content and highlights you may not have heard on the podcast. In addition, please subscribe to the podcast on Spotify or Apple, and why not leave a 5-star review? If you're not following me on social media, you can find me at Ethical Change Agency on Instagram, LinkedIn, Facebook and YouTube, and at DJ Bindi on TikTok and Instagram.
Welcome to Entrepreneurs Exposed, where we dive into the stories of visionary entrepreneurs revolutionizing the workforce. Our ongoing mission is to showcase founders and creators doing amazing things in business and beyond. If you're a founder, CEO, tech enthusiast, or someone generally interested in startup land, join me, Adam Levinter, as I dive into what makes an entrepreneur an entrepreneur. Find us wherever you get your podcasts.
Electricast.
Everyone has heard about the U.S. space program, but what is actually going on at NASA? Get the real story in 4 minutes or less with the NASA Daily podcast from Electricast. Join astronauts and researchers as they conduct groundbreaking experiments, work on the International Space Station, and reach for the stars. NASA Daily, your cosmic update.
Electricast.